The ilioischial line is a part of acetabulum represented is the posterior column and the cortex of the quadrilateral surface. So this blue line, that is the ilioischial line, indicates the posterior column. Then the iliopectinal line, which is the red line, which indicates the anterior column of the acetabulum. Then the radiographic roof, so that is the green, is the radiographic roof, that is the weight-bearing dome. Then the teardrop, which is the yellow line, and the lateral limb is condyloid fossa, and the medial is the obturator canal. Then the anterior rim, this is the black line, that is acetabulum-obturator line, represents the anterior wall, and the posterior rim, the brown line, which is ischioacetabular line, which represents the posterior wall of the acetabulum. So coming to the acetabular depth, the radiographic appearance of the coxa profunda of an anteroposterior view, pelvic view is there. The line A represents the ilioischial line, and the line B represents the floor of the acetabular fossa, which is medial to line A. We can see it has been crossed over. So it's a similar pathological condition can also be seen on the radiograph of the patient's left hip too. So here we can see the radiographic appearance of a protrusio acetabular with the medial aspect of the femoral head medial to the ilioischial line. It has been crossed the ilioischial line. Next, coming to acetabular inclination, it is classified into three broad groups: normal, increased, or decreased, and it is based on the degree of Stoney's angle. So what is Stoney's angle? The angle formed by the line 2 and 3 is the Stoney's angle. Here we can see a line, and with the line 2 is parallel to the line 1, and line 3 is towards the upper lateral edge of the acetabulum, and the line formed by 2 and 3 is the Stoney's angle, and it indicates the acetabular inclination. The acetabular having a Stoney's angle of 10 degree, 0 degree to 10 degree are considered normal, whereas those having an angle of greater than 10 degree or less than 0 degree are considered to have increased or decreased inclination. The acetabular with increased Stoney's angle are subject to structural instability, whereas those with decreased Stoney's angle are at high risk of syncipate femoroacetabular impingement. The acetabular coverage of the femoral head, the lateral central edge angle and the femoral head exclusion index. Coming to each of them. The lateral central edge angle or the central edge angle of Weber is obtained from an anteroposterior pelvic radiograph and can be used to assess the supralateral coverage of the femoral head by the acetabulum. Useful measures of acetabular coverage of the femoral head, and its value less than 25 may indicate inadequate coverage of the femoral head. So this is the transverse pelvic axis, and the line perpendicular from the center of the head is the perpendicular to the transverse pelvic axis is drawn, and a line to the lateral dorsal is drawn. And the angle formed by these two lines gives the lateral central edge angle, and it gives the acetabular coverage of the femoral head. Next, femoral head exclusion index. It indicates the degree of acetabular coverage. The femoral head exclusion index indicates the percentage of the femoral head not covered by the acetabulum and is considered normal if it is less than 25%. So here we can see D by A into 100 is 45, which is normal. If it is less than 25, it is abnormal. Next, coming to the anterior central edge angle. The anterior central edge angle or angle of Lindsay is created on the false profile view and is designed to assess the anterior coverage of the femoral head. So here the technique for calculating the anterior central edge angle on a false profile radiograph is shown here. A vertical line is drawn from the center of the femoral head. A second line is drawn through the center of the femoral head, passing through the most anterior point of the acetabular sources. And the angle created by the intersection of these two lines is the anterior central angle. If the value is less than 20 degrees, can be indicative of structural instability. Next, coming to the acetabular version. The retroverted or anteverted on the basis of the presence or absence of the crossover or figure of 8 side. An acetabulum is considered to be anteverted if the line of the anterior aspect of the rim does not cross the line of the posterior aspect of the rim before reaching the lateral aspect of the sourcil. The retroverted means if the line of the anterior aspect of the rim does not cross the line of the posterior aspect of the rim before reaching the lateral edge of the sourcil. So here in the image we can see the radiographic appearance of the anteverted acetabulum, which the line A and P does not cross over when it's reached on the lateral sourcil. But in retroverted, this is a figure of 8 appearance or the crossover sign, where the A and P before reaching the lateral sourcil has got crossed over, and the radiographic appearance of the retroverted acetabulum is the crossover sign. Next, coming to head sphericity, it is imperative to assess femoral head sphericity on both the anteroposterior and lateral radiographs. The most template is a concentric circle can be used as a reference. If the femoral epiphysis extends beyond the margin of the reference circle by more than 2 mm, the femoral head is considered spherical. And if the epiphysis of the femoral head does not extend beyond the most template by more than 2 mm, it is considered spherical. So here we can see the radiographic demonstration of the spherical femoral head, and the circle is the most template, and on femoral head with persist-like deformity is shown in the right image. Next, coming to the position of the hip center. With use of an anteroposterior pelvic view, the position of the hip center can be evaluated. Lateralized or not lateralized on the basis of the position of the medial aspect of the femoral head related to the ilioischial line. The hip center is considered to be lateralized if the medial aspect of the femoral head is greater than 10 mm from the ilioischial line, and not lateralized if the medial aspect of the femoral head is 10 mm or less than from the ilioischial line. So, this is a radiograph demonstrating the normal position of the femoral head. So, it is a distance less than 10 mm and it's normal. And if it is more lateralized, the distance will be greater than 10 mm, and this is the lateralized femoral head in patients with dysplastic hip. Next, coming to head-neck offset and head-neck junction. Anterior aspect of the femoral head-neck junctions can be classified in relation to the posterior aspect of the femoral head-neck junction on the basis of the gross appearance of the radius of curvature at each location. If the anterior and the posterior concavities are grossly symmetric, the head-neck junctions can be defined as having a symmetric concavity. So, here this is the most template, and normal or the symmetric concavity is shown in the figure 1, and the figure 2 we can see anteriorly there is a mild impingement cell, and it's a moderate reduction in the head neck offset, or a mild cam impingement can be seen here. And in the third image, anterolaterally head neck prominence can be seen. Other useful quantitative measures of head neck junction deformities include the alpha angle and the head neck offset ratio. The alpha angle, how the alpha angle is measured. First of all, a line from the center of the femoral head to the point on the anterolateral aspect of the head neck junctions, where the radius of the femoral head first becomes greater than the radius of the femoral head, found more centrally in the acetabulum. So, a line is drawn, and a line drawn through the center of the femoral neck connecting to the center of the femoral head is drawn, and the angle formed by these two lines is alpha angle, and an angle greater than 42 degree are suggestive of head neck offset deformity. Next, head neck offset ratio. It is determined by 3 lines. A line is drawn through the center of the long axis of the femoral neck, and a line parallel to the line through the anteriormost aspect of the femoral neck is drawn, the second line, and a line parallel to the line that the anteriormost aspect of the femoral head is also drawn. 3 lines are drawn, and the head neck offset ratio is calculated by measuring the distance between the line 2 and 3, this distance. and dividing by the diameter of the femoral head. If the ratio is less than 0.17, a cam deformity is likely. Coming to the congruency, congruous or incongruous on the basis of the subjective assessment of the degree of conformity between the femoral head and the acetabular. So this is congruent. We can see to parallel. It is almost parallel, the acetabulum wall and the dome and the femoral head. This is mildly incongruent. It is converging. And the other one, it is completely incongruent. It is not parallel. Osteoarthritis of hip. The degree of presence in each hip can be determined with use of Tönnis classification system. Grade 0 represents there is no sign of osteoarthritis, and grade 1 there will be increased sclerosis of the head and acetabulum, slight joint space narrowing, and slight lifting of the joint margin. In the grade 2, a small cyst in the head or acetabulum, moderate joint space narrowing and moderate loss of sphericity of the head will be there. And the grade 3, large cyst in the head or acetabulum, and a joint space obliteration and severe joint space narrowing and severe deformity of the femoral head or evidence of necrosis will be there. So here in the first image is normal, and then in the second one we can see a slight joint space narrowing on the upper part. Joint space has narrowed, and a mild sclerosis of the acetabulum, and it is grade 1 or grade 2. Next, coming to grade 2, there will be a moderate joint space narrowing, a small cyst on the acetabulum, and the mild loss of head sphericity will be there. And in the grade 3, in this last image we can see there will be severe joint space narrowing with large acetabular or femoral head cyst or more dense sphericity of the femoral head. The other things which can be assessed from the radiographs, plain radiographs, are the neck shaft angle, which is normally 130 degree, and this is the increased angle and the decreased angle, this is coxa vara and coxa valga. Then coming to Shenden's line. Shenden's line is an arc along the inferior border of the femoral neck and the superior margin of the obturator foramen, which should be continuous. Then coming to the Hilgenbrunner and Perkins line. The Hilgenbrunner line is the horizontal line through the right and left triradiate cartilage. So this is the Hilgenbrunner line. Here the femoral head ossification should be inferior to this line. So here we can see it is inferior and it's normal, but here this plastic hip, it is not inferior, it is superior to the Hilgenbrunner. Then the Perkins line, the line perpendicular to Hilgenbrunner's line through a point at the lateral margin of acetabulum. So from the lateral margin of acetabulum, a line passing through perpendicular to the Hilgenbrunner line is the Perkins line, and the femoral head should be medial to this line. Here it's medial, but when coming to this plastic side, it is not medial, it is lateralized. Then the acetabular index, it is formed by the Hilgenbrunner's line and a line drawn from point on the lateral triradiate cartilage to the point on the lateral margin of the acetabulum. So this is the Hilgenbrunner's line, and the line drawn from the triradiate to the lateral acetabular margin forms the acetabular index angle, and it should be less than 25 degree in patients older than 6 months. Then Klein's line is a line along the superior edge of the neck of the femur, and abnormal when it is passes lateral to the proximal femoral epiphysis, and it represents it is seen in Skiffy. So these are the fundamentals about the radiographic evaluation of young adult hip. That's all my topic. Thank you.
Matthias covered it technically. Of course, there are a lot of information. One, I think it will not be possible to remember all, but really more popular must be thorough. That means you must know, and try to practice as much as possible. Yes, sir.
Morning. I joined a little late, so I did not see the earlier slides. Matthew, did you mention about, of course, the new one of the slides? I think Matthew may mute your presentation.
Sir.
Did you mention anything about the present concept about the pelvic and acetabular fractures, the lines which are drawn? Because that is also assuming importance to.
Yes, sir.
Right,
Really?
okay. Yeah, right. I did not see that actually, because usually a template is given while taking up the course, and that is kept over the acetabulum and then decided whether it is an anterior fracture, posterior fracture,
Yes, sir.
ilioinguinal, etc. Because that's also coming into the picture. When we were students, we could get away by knowing that's correct. I did not see that. That's why I asked you to put it across. Okay, that's good. The point is, when we were students, we were taught this even tendons and that Hirschberg angle, that Goldberg angle, etc. That's enough for, I mean, and again, flying, that was enough. But as our knowledge increased, we had to move up with this thing. And these sort of things will be definitely asked in there. The ideal thing is to keep some sort of template there and then measure it, because this is very important for understanding the basic pathology and sometimes take an appropriate position. And, especially nowadays, the 3D reconstruction models are available so that custom-made processes can be made. Probably Dominic can say something about it, but especially when you are dealing with fractures, some understanding about these sort of lines, etc., will help us and tell them about the manufacture of custom-made processes, etc. So, reading the pelvis X-ray, most important thing I would say from the undergraduate level is to get an X-ray of the pelvis with both hips AP view. Never be satisfied with an X-ray of one hip. You may not be able to make a pathology without seeing the so-called normal hip on the other side. That's very important. And then you should see at least the proximal third of the femur, not just at the level of the lesser trochanteric lobe. So a proper X-ray should demonstrate from L5S1 to L5, I mean at least L5, the sacral upper limit, because you have to know certain basic anatomical facts with respect to the iliac crest, the Shenton's line, the lesser trochanter, etc. to assess this thing. So getting a proper X-ray is the first basic thing. Second thing is, depending upon the necessity, you can go in for lateral view, oblique view, etc. Some of those views which were used in the past are becoming redundant these days because of 3D reconstruction of the CT, with a CT scan. So we will be losing that technique of flowing a few fundamental things. As Dr. Dominic already put it very clearly, that you should know the basic lines which are essential. I would say that you should know the Hilton-Reader, the Shenton's line, and then the other lines which you have mentioned. Of course, this should never be forgotten about the anteroposterior, so various landmarks with regard to pelviacetabular reconstruction also. That's all I need to examine. And then you are asking for an X-ray of the pelvis. For a trauma lesion, yes, but for other lesions, you must probably ask the patient. If it is not an acute emergency, then probably it is better to get a bowel evacuated and then get a proper X-ray, so that you may not miss something in the sacrum, symphysis, pubis, etc., because of the overlying gas shadows. That is another point which should not be forgotten. And you should try to read the X-rays systematically from one end to the other, so that it can be compared. These are some of the few points which I wanted to add on.
Regarding the customary processes, we had problem because in one case of addition in the upper femur, we had a dislocation, and because a lot of factors are playing, and now we are using what is known as dual mobility cup for upper femur lesion. If Dijo is here, he can contribute something because Dijo, are you hearing? Because these are technical aspects, the anti-version and all the placement of the are all very difficult to assess. If I personally cannot clearly say anything about that. It is very important in the replacement, as Jayprakash said. Now we are dealing with a dual mobility uh, femoral head. That has solved some other problem.
Dr. Dominic, you asked me something.
Hello, sir. എന്താ സാറിനെ വിളിക്കാൻ പറഞ്ഞു?
അല്ലല്ല എന്താ എന്റെ അടുത്ത് എന്തോ ചോദിച്ചു എന്ന് വിചാരിച്ചു. ഓഡിയോ വാസ് നോട്ട് ക്ലിയർ.
അല്ല, സാറ് പറഞ്ഞ പോലെ ഈ മറ്റേ കസ്റ്റമർ പ്രോസസ്സിൽ ഇത് ലൈൻസ് ഇമ്പോർട്ടന്റ് ആണെന്ന് പറഞ്ഞേ.
ലൈൻസ്
അല്ല, ഈ അതിന്റെ ആന്റിവേർഷൻ ഒക്കെ ഡിസൈഡ് ചെയ്യണതേ.
It's very important. That's how you can reconstruct it. Number one. Number two, you should get the opposite side also. That's what is supposed to be normal for this patient. നമ്മുടെ ആ പിന്നെ പെൽവി അസറ്റാബുലാർ കോഴ്സിന്റെ ഫയൽ എങ്ങാനും അവിടെ ഉണ്ടെങ്കിൽ, ഐ ഡോണ്ട് ഹാവ് ഇറ്റ്, അതിനകത്ത് ഒരു ടെംപ്ലേറ്റ് ഉണ്ട്. അതായത് it might be there in one of the CME files. I am not very sure. Somebody has to search it, or you ask our Suchita. She might know where it has been kept. ഒരു ടെംപ്ലേറ്റ് ഉണ്ട് ആ ഫയൽ. I don't know. അത് ആ ടെംപ്ലേറ്റ് ഉണ്ടെങ്കിൽ that template can be kept over a pelvic section. എന്നിട്ട് അത് വരയ്ക്കാം. അതാണ് അത് നമ്മൾ അന്ന് മറ്റേ CME നടത്തുമ്പോൾ we had given it in the file format to everybody, and then we were asking them to draw the lines and identify them in the first session itself. That will give us a clue how much the participant has baseline knowledge about this thing. There was a template which we gave to everybody in that file. If that file is there, there is a template there. I don't have it in my house because I had probably kept it there. The third course was abandoned and aborted because of this COVID, so I don't have it. We can probably get one from the mission if we come across him again. With that, because our postgraduate students should learn about it. Once they start using that, then they will become familiar. From the undergraduate point of view, if they know something about sentence line, they should be excused. Is he on?
I have joined late. It is a good topic anyway. Nothing more to add as it is.
Wilson sir, when we were students in the olden days, we never were bothered with so many lines.
That is true.
Now everybody knows many lines, which they do not know when to cross, when not to cross. That's the problem.
No. With the fracture pelvis fixation, these lines are all now very important.
That's why I suggested about that template on pelvic acetabular fractures, which unfortunately I happen to be the chairman of the international conference. Leo, you trying to find out? ഏതെങ്കിലും ഫയലിനകത്ത് കാണും. It can be very useful. You can make some also. അതിനെ stenciled ആണ്, പിന്നെ cyclostyling paper പോലത്തെ സാധനത്തിലാണ്. So that you can take copies എടുക്കാനും പറ്റും and give it to all the PGs so that they can have a copy of it.
Okay, sir.
അത് നമ്മുടെ ഓവർഹെഡ് പ്രൊജക്ടറിൽ യൂസ് ചെയ്യണ പേപ്പർ ഇല്ലേ, അതേപോലത്തെ അതിന്റെ കോപ്പീസും it is there on the shelf. You can take so many copies from that and probably whatever you can give it to them. It is there.
ഞാൻ നോക്കിയിട്ട് സാറിനെ അറിയിക്കാം സർ.
Right. Because other people കാണിക്കുന്ന അത് വലിയ ഇമ്പോർട്ടൻസ് ആണ്. Acetabular fractures, fracture fixation. At least some of you will have to specialize on that, and that will definitely help.
ഈശ്വരൊന്നും ആഡ് ചെയ്തില്ലല്ലോ.
Sir, nothing much to add. Only thing is that the PG should try to internalize what you have described. You should be able to draw and visualize these lines on the X-rays when you see an X-ray. So whenever you see a hip X-ray, try to find out where the Shenden's line should be. This is a Shenden's line. So you do that for multiple X-rays. Then you will be able to remember that. Similarly, on another occasion, you concentrate on the ilioischial line. You concentrate on the iliopectineal line. So only if you repeatedly try to visualize these lines in the X-rays, all these things will be lost. It is very difficult to remember all these things. So that is the only thing I have to add. There is no point in discussing these things as a theory. You should be able to practice that in your clinical setting or in the examination hall. So in the examination hall, when the examiner asks you, draw the Shenden's line. If you cannot draw that, there is no point in discussing like this.
Kishore,
So you
let me interrupt. I will also
Yes, sir.
ask who was Shendan.
Was he a doctor, Matthew?
Matthew,
Sir, അറിയില്ല.
his name is Shendan's line. Let me know.
I don't know.
You said something about
Radiographer,
Shendan.
radiologist ആയിരുന്നോ? MD radiologist ആയിരുന്നോ?
Kishore, don't pull his legs down.
അല്ല.
Anybody from our postgraduate is there. Why is it named Shendan's line? Which is more than some 70 years old, that line, probably. Anybody? There is one question one examiner might ask and get you into trouble. I mean, you are not going to fail on that count, but that will show how much you have learned about. I don't see anybody coming up with an answer. Edward Warrenheim Shendan was a radiographer in Guy's Hospital, London. He drew the attention of the then consultant orthopedic surgeons in those areas, probably in the 1960s or even earlier than that, about the possibility of drawing a line like that, and that will show us whether there is a fracture or a dislocation of the hip. So Shendan's line is named after him because he has nothing to do with, he was a radiographer, chief radiographer, but not a radiologist or a doctor in that sense, because in those days radiographers used to work in those departments throughout their lifetime, and they become perfect tutors for the junior people who come into this thing. Dr. Dominic and myself will know the importance, the things which we learned from our nursing assistant Kalapan as well as Baleshwar Nair in Calicut. They were nursing assistants, but they taught us a lot of things about plastering, how to hold them and things like that. So we learned a lot of things from that. That's how Shendan's line was named. It's something which is a trivial, which you call it as a trivia, but then you should know why you are saying something. That's what I try to know about all these lines, Reiberg, Hilgen, Reiners, etc. Because you should know about under what circumstances they were described, and then you might come across some surprising facts. Well, probably we are using those things for a different purpose, which the original intended the person which mentioned about it never knew. That is the problem. Okay, I have nothing more to add. Shall we call it a day then?
Okay, sir.
Okay, bye-bye.
Thank you, sir.
Okay, sir.